Welcome to part 2 of 2 videos on the pelvis and hip. So we'll continue and look at this time single bone fractures and then avulsion fractures of the pelvis and finish up with hip dislocations and hip fractures, making sure that we can differentiate between the intra and the extracapsular forms.
It is possible to get a single bone fracture in the pelvis, and these are stable fractures. So we tend to see these in elderly patients who have osteopenic bones. And helpfully, they usually have quite localized pain. Generally speaking, treatment is early mobilization, and although they may have significant pain for the first few days, it won't last, and they should be able to mobilize quite easily within a week or so. So when you look for single bone fractures, the classic locations are the pubic and ischial-pubic rami. You will also need to search your iliac wings, because you can sustain what's referred to as a Diverny fracture, which is a fracture of the iliac wing. And elderly patients frequently fracture their sacrum. You can get fractures of the coccyx, but we don't image the coccyx for a very specific reason. The coccyx can be, there's a wide range of different types of appearances of the coccyx, which are normal, including some that are really significantly angulated. And so it becomes really quite difficult to distinguish between an abnormally angulated coccyx and a fracture through the coccyx. And because the management of the patient doesn't change, i.e. there is no treatment for it, that's why we don't image, because of the misleading range of normal. Fractures to the iliac crest are inherently stable, and that's because it doesn't involve the weight-bearing portion of the pelvis. Now, a fracture to the iliac crest, otherwise known as a Diverny fracture, is usually caused by a direct blow or a crush injury. However, they are at risk of complications, which include bowel perforation and internal bleeding. So remember, when you're looking at a pelvis, because it's very complicated, you have to have a good search strategy. So remember, you want to scrutinise the main pelvic ring, both the inner and outer contours. So with the inner contours, you want to be looking at the iliopectoral line, you want to look at the ilioischial line, you want to check your obturator foramina, you want to make sure that your symphysis pubis is no more than 5 millimeters. And whilst you may get a step of 1 or 2 millimeters between the symphysis pubis, which is normal, any more than 1 or 2, and then that becomes an abnormality. You want to carefully scrutinise your acetabulum, which includes your roof, and the anterior and the posterior cortex. You want to look at your SIJs, check your sacral foramina, which might indicate an underlying sacral fracture. And when you're carrying out this search strategy, it will be checking the outer contours that will enable you to identify the Diverny fracture. And we can see here quite clearly that we've got this marked lucent line, and we even have a small fracture fragment, which is that increase in density. So we do have a comminuted fracture. So what is it? It's a Diverny fracture. Where? It's the right iliac wing. How? Comminuted. Fractures to the pubic or ischial rami are relatively common. You usually see them in elderly patients who sustain minor trauma, so essentially fall from standing, so a fragility fracture. And whilst they can occur in pairs, they can also be, as is with this case, a single bone fracture. And the key thing with these injuries is that they are associated with groin pain. Now, a neck of femur fracture can also be associated with groin pain, and a neck of femur fracture is more common than a pubic rami fracture, and so therefore they clinically get misdiagnosed as being query neck of femur fracture. So it's important that in all patients where you're examining for a neck of femur fracture to make sure you scrutinise your pubic initial rami very carefully. So as always, you want to have a really good search strategy with the pelvis, which I'll just keep repeating over and over again as we go through. So you want to check the outer contours of your pelvis, go all the way around. You then want to check your inner contours. So it will be with your iliopectinal line that you will be able to identify this fracture through the right superior pubic rami, because you will see a disruption in the cortex. And it will also be your examination of the obturator foramina that will also identify this. So you'll be able to identify this fracture in two locations, the obturator foramina and the iliopectinal line. Always remember to check your ilioischial line. You do this on both sides. Have a look at your symphysis pubis. Is your symphysis pubis normal? Look at your SIJs. Make sure that there's no diastasis through here. And importantly, check your sacral foramina for any breaks in the cortex. And then finally, of course, remember to check your acetabulum. So you want to be looking at your acetabular roofs. In this case, because of the total hip replacement, you won't be able to see the anterior and posterior cortex of the acetabulum, but you can check your acetabular roof. Look at your anterior and your posterior cortex of the acetabulum. So what is it? It's a fracture where it's the right superior pubic ramus, how slightly displaced. Isolated fractures to the sacrum are really quite rare, and they usually occur with other pelvic injuries. However, as it is with this patient, we do have an isolated fracture. So what's going to help you with looking for a sacral alar fracture? Well, of course, always check your SIJs, and of course normal is 2 to 4 millimeters. So you're looking for potential disruptions to this. Maybe a step between the pelvic rim and the corresponding sacrum. But the really helpful clue is to look at our sacral foramina. And the sacral foramina are surrounded by a thin sclerotic curved line, and it's these lines that you want to be looking for. And if you see any steps in these lines, as we have here on our left hand side, we can see that there's a break through the foramina, and this indicates that you've got an underlying fracture to the sacral alar. So it's important when you do scrutinise your pelvis x-ray to make sure that you include looking at your sacral foramina, otherwise you will miss fractures. You can get insufficiency fractures to the sacrum in elderly patients. However, they can be really hard to detect, and usually it's a bone scan that will identify that they've got a insufficiency fracture. And the classic appearance on a bone scan is that it looks like a letter H, so it's sometimes referred to as the Honda sign. So when you're evaluating this image, remember you've got to look at the inner and outer contours of your pelvis. You need to look at your obturator foramina. You need to check your symphysis pubis, and then you need to look at your sacral foramina. So it's when you scrutinise the sacral foramina on this image that you'll identify the fracture. And then finally, you need to look at your acetabulum. So what is it? It's a fracture where it's the left sacral alar, how minimally displaced. Avulsion fractures in the pelvis tend to occur with adolescents who are participating in sporting activities such as gymnastics and long jump. what happens is that they get a really forceful muscle contraction, and that pulls off one of the apophyses. So it's really important that you know all the apophyses in the pelvis so that you can check these areas particularly carefully in young people. Now remember, an apophysis is responsible for width, and it's the site growth in width, and it's the site of insertion of muscles and ligaments and so on. And so we have on the top, the iliac crest is where the abdominal muscles insert. The anterior superior iliac spine is where the sartorius inserts. Your anterior inferior iliac spine is where your rectus femoris inserts. Your greater trochanter is where your gluteus medius and minimus inserts. Lesser trochanter is the iliopsoas. Your hamstrings insert to the ischial tuberosity, and finally your ductus insert to the symphysis. Now, the ischial tuberosity, where your hamstring inserts, this is the most common site for avulsion fractures, followed by the anterior inferior iliac spine, and then the anterior superior iliac spine. Greater trochanter avulsion fractures are particularly uncommon. So the great thing about pelvis is that you can always compare sides, and particularly with avulsion fractures in paediatrics, it's always helpful to look at the opposing side to see if it looks the same or if it looks different. And if you look carefully along our iliac crest here, we can see the iliac crest apophysis on both sides, but we can see that the lateral portion of the right iliac crest has there's more diastasis there in comparison to the left hand side, and we can see that the fracture actually extends superiorly, so it has avulsed a small piece of bone off that location. So if you look carefully, there isn't much displacement, and so it's really quite subtle, so you do have to scrutinise these areas carefully in order to identify the avulsion fracture. So what is it? It's an avulsion fracture. Where? It's the right iliac crest. How? Minimally displaced. Okay, so here we have an avulsion of the anterior superior iliac spine, and where the sartorius inserts. So when we check our pelvis, as always, we look at the outer and inner cortices, and it's going to be the assessment of the outer cortex that will allow you to identify this abnormality. So remember, we always compare opposite sides because that's really helpful, and you can see that the anterior superior iliac spine on the right is clearly is not detached. There's a smooth cortical line without evidence of disruption, and yet on the left we can actually see that it has been slightly pulled away from the adjacent host bone, consistent with an avulsion fracture. Don't forget to then also assess the inner cortex, so look at your iliopectinal line, look at your ilioischial lines, don't forget to look at your symphysis pubis, your SIJs, sacral foramina, and of course look at your Shenton's lines, and look at your femoral necks and so on, and then look at the acetabuli. So what is it? It's an avulsion fracture. Where? It's the left anterior superior iliac crest. How? Slightly displaced. And here we have an avulsion of the anterior inferior iliac spine at the insertion of the rectus femoris. So this is the second most common avulsion fracture. And again, when we look around the outer cortex of the pelvis, this is where we'll be able to identify this avulsion fracture. And again, if you compare the opposing side, we can see that you've got a piece of bone detached with a clear lucent line between the avulsed bone and the host bone, whereas in comparison on the left you've got a nice smooth cortex and no evidence of an avulsion at all. As always, when you're looking around the pelvis, you need to make sure that you look at your inner cortices, so you're looking at your iliopectoral line, your ilioischial line, look at your pterygoforamina, your symphysis pubis, your SIJs, check your sacral foramina, look at your Shenton's line over your hips, look at the acetabulum, and of course look at your hip structure. So what is it? It's an avulsion fracture where it's the right anterior inferior iliac spine, how slightly displaced. Avulsions of the lesser trochanter where the iliocervix inserts aren't particularly common, but they do happen. The important thing with this image is that it demonstrates that you have to look at the entire film. So when you have a single pelvis x-ray, don't just concentrate on the pelvis itself, you will need to look at your proximal femora and the femoral heads. So if we look carefully on the right, we can see how the lesser trochanter is smooth in outline with no evidence of a fracture. In comparison, the left is uneven. We can see that there is a deformity where the avulsed fracture fragment has been detached from. As always, it's so important to compare sides. So if you're ever in doubt, look at the other side. Does it look the same? If it looks the same, then you can be more confident that there isn't an abnormality. And if the opposing side is not symmetrical, then you can be more confident that there is an abnormality there. So what is it? It's an avulsion fracture where it's the left lesser trochanter, how slightly displaced. Hamstring avulsion fractures are really quite common, and so it's important to make sure that you scrutinise your ischial tuberosities carefully. You can see how there's only a tiny sliver of bone that has been detached from the adjacent host bone of the ischial tuberosity. And so, as always, as I keep saying, check the opposing side. If it looks the same, then it's probably normal, and if it looks different, if it lacks symmetry, then it's most likely where you have an avulsion injury. So as always, when you're evaluating the whole of the pelvis, it will be when you're checking the outer cortex of the pelvic ring that you'll be able to identify this injury. But you will still need to keep checking the iliopectoral line, the ilioischial line, look at your pterygoforamina, your symphysis pubis, your SIJs, your sacral foramina. Don't forget to look at your acetabulum, and of course the surrounding the bilateral femurs. So what is it? It's an avulsion fracture where it's the left ischial tuberosity, how minimally displaced. When we talk about dislocation of the hip, it's very important to recognise that this is in a patient who does not have a hemiarthroplasty or a total hip replacement. So dislocation of the hip is to do with patients who still have a normal bony acetabulum and a normal femoral head and neck. They're usually the result of a high-speed trauma, so most of these patients, or 50% of these patients, are involved in motor vehicle accidents, whereas falls and sporting injuries are much less common. 85% of these patients suffer a posterior dislocation, whereas an anterior it's only seen in 10%. Now, unsurprisingly, if you have a central dislocation, so i.e. there's protrusion of the femoral head, it will then go through the acetabulum, so you will have an acetabular fracture. So the biggest complications to dislocation of the neck are avascular necrosis, secondary degenerative changes due to trauma, and then sciatic nerve damage. Now, we've discussed this briefly in the knee presentation, but if you have a dislocation of the hip and you do not have an associated pelvic fracture, such as the acetabulum, You need to then scrutinise the knee, because more often than not there will be a further fracture of the around the distal femur or the knee joint itself. We can quite clearly see the abnormality on this image where the femoral head is not congruent with the adjacent acetabulum. But the important thing to evaluate is the acetabulum to see if there are any associated fractures. And you should also look particularly hard at your ilioischial line and your iliopectoral line. Now, although this X-ray is quite obviously demonstrated that the head of the femoral head has not displaced centrally, you should still check carefully to make sure that there's no disruption to the acetabulum. And as this case doesn't feature an associated fracture, the patient will need to have knee X-rays to exclude a more distal fracture. So what is it? It's a dislocation where it's the left hip. Now, on this single view, you would describe it as a superolateral displacement because the femoral head has moved laterally to the pelvis and has projected superiorly. But because this is a dislocation where it's of a normal, it's not of either a hemiarthroplasty or a total hip replacement. In fact, most of these dislocations are either posterior or anterior, and so therefore, if you had the corresponding horizontal bilateral hip, you would use your HBL view to dictate your how, whether it's going to be posterior or anterior. Okay, so the how in this image is just on this single view, but if you have an HBL hip, you would use that second view to determine how you would describe the direction. The more commonly encountered hip dislocation are patients who have had a hip replacement and they sustain a dislocation of their femoral head and stem. So patients who have had hemiarthroplasties, and by hemiarthroplasty, so remember hemi means half, so it's half replacement. So essentially patients with a hemiarthroplasty, they have retained their normal acetabulum, their acetabulum has not been replaced. So there's only been a replacement of the femoral head and stem. People with total hip replacements like this patient here, they have had both the acetabuli replaced as well as the femoral components. So a total hip replacement is when the acetabulum and the femoral component is replaced, and a hemi is when it's only the femoral components replaced. So when you have a hip replacement, you are told not to cross your legs, and you shouldn't bend your knees more than 90 degrees. So essentially that means don't sit in a low chair, and you shouldn't sleep on the affected side. But there are other reasons, such as if it's been malpositioned in theatre. If you've had a revision replacement, that increases the likelihood of a dislocated. And if you have patients with neuromuscular problems such as Parkinson's, so they're more at risk of sustaining hip dislocation. Now, unlike a hip dislocation of a patient who does not have a hip replacement, the most common dislocation is superolateral. So we can quite clearly see on this image that the femoral head is lateral to the acetabulum, and it has migrated superiorly in relation to the patient, to the pelvis. So it's a superolateral hip dislocation, as opposed to patients who don't have hip replacements who dislocate the hips, where it's normally going to be either posterior or an anterior dislocation. Important things to look out for with a hip dislocation is to look for any periprosthetic fractures. So you want to go around the whole of the stem and look for any breaks in the actual metalwork, and then you want to actually look at the bone themselves and see if there are any small breaks in the cortex, because you can get periprosthetic fractures associated with these. So it's something to be aware of. So what is it? It's a dislocation of a total hip replacement, where it's the left hip. How? So you've got superolateral dislocation of the femoral stem from the acetabular component. Hip fractures, as I'm sure you're all very aware, are really common injuries. And it's anticipated by the time we reach 2020, we're going to be looking at around about 100,000 hip fractures per year because of our increasingly elderly population, and that bill is estimated to rise to about 2 billion. So it's a huge burden on the NHS. So most people who sustain hip fractures are females, and around about 10% of patients who sustain a hip fracture will die within the first month, and 2/3 will die within 12 months. So it's a really significant injury. But it's not actually the injury that causes those people's death, it's to do with associated conditions. And so basically what that means is that patients have a high prevalence of comorbidities. So with fracture classification, we always consider about intra-articular and extra-articular. So intra-articular means it communicates with the joint, and extra-articular means that it doesn't extend to the joint. But in the hip, it's slightly different, because with hips, the blood supply enters distal to the femoral neck, and so therefore we become concerned about whether a hip fracture is intracapsular or extracapsular. So if the fracture is intracapsular, what that means is that the blood supply is going to be interrupted, and so then there will be high risk of avascular necrosis. So when you talk about your hip fractures in your what, where, how, you need to identify whether it's an intracapsular injury or an extracapsular injury. So if you look onto the right hand side, the red line identifies a subcapital injury, and these are particularly difficult to see. So what you're looking for is to evaluate the trabecular pattern, and if you have any kind of increase in sclerosis, so a sclerotic line, i.e. a white line, which might suggest that you've got an impacted fracture. And the problem with these is the really high risk of avascular necrosis. Now, orthopods use what's referred to as the golden classification, which means that if you have a fracture if you have a golden classification 1 or 2, it means that the patient can be fixed with cannulated screws. But if they have a golden classification of 3 or 4, then basically they're going to have to get rid of the femoral head and then replace it with a hemiarthroplasty or a total hip replacement. You don't need to use the golden classification in your what, where, how, because we don't use orthopedic classifications in image interpretation, with exception of, I think it's just the ACJ. But with regards to the hip, you don't need to use that. It's just for a point of reference. Now, a transcervical fracture, like the subcapsular fracture, is also at risk of avascular necrosis because the blood supply is going distally. And what will help with evaluating the femoral neck is using Schindler's line, where you run along the inferior cortex of the superior pubic rami and then run it down along the medial cortex of the femoral neck, and you should get a nice smooth line. So if you have any disruption to Schindler's line, that might indicate that you have a displaced basis transcervical fracture. Now, basicervical fractures can be quite difficult to identify. So, in which case, the more common fracture, the intertrochanteric fracture, is more commonly seen. I wouldn't get too worried about basicervical. For me, I think it's more about recognising an intertrochanteric fracture, because I just think that basicervicals are really quite hard to see. The important thing though about the intertrochanteric and basicervical fractures are that these are now extracapsular, so they've got a really good prognosis. And subtrochanteric fractures, so whether it's of the lesser trochanter or of the greater trochanter, these are usually quite easy to identify. And again, as I said, they're extracapsular, so there's going to be no problem about overlooking them, because usually they're quite often very comminuted. So these are the really tricky injuries to spot. If you look carefully, you can see an increase in sclerosis across the femoral neck, indicating that you have an impacted fracture. The reason why they're so tricky is that if you look at your Shenton's line, it hasn't actually been disrupted. And so this is why you have to pay particular attention to not only all the cortices and draw in all your lines and look at all your joint spaces, but you do have to consider the trabecular pattern. If you look at the normal trabecular pattern on the right, we can see that the trabeculae hasn't been interrupted and there's therefore no impaction. So what is it? It's an intracapsular fracture where it's the left subcapital neck of femur, how it's impacted. So the extracapsular fracture, in this case, it's a intertrochanteric fracture. These tend to be really comminuted, and we can quite see this big chunk hanging off here, and there's another big chunk over here. And importantly, it's important to recognise where the distal portion of the femoral neck is and where the proximal portion of the distal fragment is. So here we can see there's really quite marked overlap of the fracture fragment. And when you look at Shenton's line, if you come along and round, we can see that it doesn't work at all in comparison to the right hand side. If you follow Shenton's line, we've got a nice smooth arch coming down through here. And now the lateral view, here we can see quite clearly that there is quite significant overlap. So here's your femoral neck, and this is the portion of the greater trochanter, and we can see that there's actually been a bit of overlap through here, which was identified on the AP film as well. So what is it? It's an extracapsular fracture where it's the right intertrochanteric region, how comminuted with overlap. Finally, I just want to cover coxa profunda versus acetabula protrusio. So coxa profunda on our left refers to deep acetabular sockets. And to evaluate whether there's a deep acetabular socket, you run along your ilioischial line. And what will happen is that the acetabular socket will be medial to that ilioischial line. Conversely, acetabula protrusio, where the acetabula protrudes centrally along with the femoral head, so both the femoral head and the acetabulum are medial to the ilioischial line. So coxa profunda is more common in females, and acetabula protrusio is normally associated with conditions such as rheumatoid arthritis and so on and so forth. So they're just two things that you need to be aware of.